and welcome to Improving Sleep Disorders Screening and Diagnosis for Women, a webinar produced by Sleep Review and made possible via an educational grant from Cadwell. I'm Sri Roy, Chief Editor of Sleep Review. I extend a warm welcome to the hundreds of healthcare professionals in our audience today, and a shout out to BRPT credential holders who are watching this event live on December 8th, 2025. If you watch for at least 15 minutes, we'll send you a certificate by the end of the month that's good for 1 CSTE credit. Everyone in attendance will get a link to the recorded event tomorrow. The recording is not eligible for CSTEs. Both presenters' conflict of interest disclosures are available in the handout section of your screen. Now I am thrilled to introduce today's first presenter. Monica Mallampalli, PhD, is President and CEO of the Alliance of Sleep Apnea Partners, which you may know better as ASAP. Dr. Mallampalli has been diagnosed with OSA. As a women's health advocate, she is also a member of the AASM Women and Sleep Health Task Force. Her former roles include being the Vice President of Scientific Affairs at the Society for Women's Health Research and a Health Policy Analyst and Research Fellow at the NIH. Welcome, Dr. Mallampalli.
Thanks, Sri. Thanks for having me here today. Today, I'm going to talk about applying the sex differences lens to screening and diagnosis as part of this presentation with focus on women's health. I have no conflict of interest in relation to this program or presentation. Just briefly, for those of you who have not heard about ASAP, we are a nonprofit charity organization, very much patient-oriented and volunteer-driven. Our mission is to promote and advocate for screening, diagnosis, treatment, and management for optimal health of those who suffer from sleep apnea. The mission is broad, but we also recognize that there are many gaps when it comes to screening, diagnosis, treatment, and management. But again, today's talk is focused mainly on screening and diagnosis. The other area we're very much focused on is the area of women and sleep apnea. And as Sri mentioned, I myself was diagnosed with sleep apnea, so this is pretty close to my heart. So why are we talking about women's health? Because there's been a lot of conversation recently around this topic, and which is pretty timely, actually. Given my background in women's health, I just sort of wanted to walk everyone through a little bit of the history, a little bit of what sex differences mean and what is the importance, why does it matter, especially in the sleep health. But before then, let me quickly give you just that bit of the history of women's health and why we're talking about this. I just want to have you focus on two of these days that I've circled in red. In 1977, women were barred from participating in research due to the fear of harming their babies. So that set us back for many years. In 1993, there was an NIH Revitalization Act that was mandated that women had to be included in biomedical research. So since then, a lot of progress has been made, but many gaps continue to exist to this day. There were also a lot of assumptions made with regard to women's health, especially ignoring the complex biology that women present, and as an excuse, unfortunately, by a lot of researchers, that it was very hard to study women because of this complex biology, the hormonal influences. So that was, again, like I said, as an excuse used by many. But I just wanted to show this graphic, which is very well presented here. As you can see, the sleep across the women, the sleep in women across the lifespan. As you can see, there's a lot of changes that take place regarding a woman's sleep, whether it's wake after onset, the REM sleep, as well as the total sleep time by the time a woman from the childhood, as well as, when she's much older. What you will also see are these changing levels of the progesterone and estrogen at the bottom of these squares. You can start to see that in adolescence and puberty, these hormone levels increase. Not only do they increase, but they also are then released into the bloodstream, and they regulate, and these are cyclically released into the bloodstream, and they regulate a large variety of homeostatic functions. such as cardiocirculatory, respiratory, metabolic systems, as well as sleep-wake cycle. And so that's what happens during the reproductive years. There is a risk for sleep disordered breathing during this time. And also something interesting you'll notice is during this puberty is also there's a changes in the EEG activity that you start to see in the brain. Pregnancy itself is a very important aspect where there are several factors that disrupt a woman's sleep. Also, this is an area that is often where OSA is often underdiagnosed and undertreated, and presumably leads to an increased risk for gestational diabetes, pregnancy-induced hypertension, and also intrauterine growth retardation. As a woman ages during the perimenopause phase, she will experience a lot of effects of menopause, such as the vasomotor symptoms that can also disrupt a woman's sleep. And during this stage in life, a woman's sleep is also more likely to be disrupted due to the caregiving role. There's also an increase, twice the risk of increase in mood disorders during the adolescence puberty. There's a greater increase in insomnia right around this time. And also you'll see an increase in OSA, insomnia, as well as mood disorders during the menopause phase. Just wanted to also briefly focus on this important area of menstrual cycle, menopause, where a lot of changes also happen during this phase. As you see, there's that cyclical changes in the hormonal levels. But what's interesting is when you look at the sleep architecture, you will see that there's an increase in the non-REM sleep during the post-ovulation luteal phase of menopause. You also see an increase in progesterone during this time. But if you look at the follicular phase, you will see there's an increase in the upper airway resistance, also lower muscle tone during this time. So what does this say? This actually suggests that, while when we are diagnosing or women during this phase, we typically do not even capture where they are in their menstrual cycle. Perhaps it's important to understand where they are in this phase so that we can accurately even capture, because what this suggests is if you're doing sleep studies during the follicular phase, you may be able to pick up the upper airway resistance during this phase as compared to the luteal phase. So just wanted to kind of share a little bit of this information. All right, so going back to sort of, again, the history aspect, they were in 2007, there was a workshop hosted by the National Sleep Foundation in Washington, D.C., and focused on women and sleep. And there were several publications that came out of this conference. And as you can, and I've noted them here, as you can see, there was a lot of discussion around how women's sleep is impacted by the biology, also the sleep disorders, and her role in home and workplace. There was a recognition of sex differences, which is how sleep disorders affect women differently as they affect men, and then again, how their different manifestations and prevalences. There was discussion around the role of biological sex as well as the reproductive hormones, and how some of these characteristics can also alter sleep states and contribute to the gender disparities. And so following this conference and the publication of papers, there were a couple other meetings after that. But then in 2013, I was at the Society for Women's Health Research, and we brought in some of the same experts and did a roundtable discussion, really focused on understanding the sex and gender differences in sleep. And this is the publication, which was, again, there was a paper published in 2014. And some of the just overall takeaways were, we realized that women's sleep was still often ignored. Women continued to be misdiagnosed, and underdiagnosis was common in women. There was a lack of awareness among women as well as their providers. And this one-size-fits-all approach was continued to be applied to research and practice. After we published that report, there was a lot of attention in the press, as well as, I just wanted to point out Sleep Review, thank you to them. They also invited us to discuss some of our findings. And then we also published this guide called Women in Sleep, just looking at in-depth, what the research and what the state of the science was And this was, I think, published in 2017, as you see the date there. So before I go further, I've already used some of the terms here. I've mentioned sex differences, I've mentioned gender. So just we'll spend a few quick minutes on understanding these differences because these are important. Sex is the biological variable. And so the differences mean it's the biological and the physiological differences that you see between males and females. And the functions are typically assigned by the chromosomal complement, and they're based on the internal reproductive organs. More importantly, they're based on the XX, XY, as well as you will see, the ovum and the sperm, and that's how they're defined. It's a term that's mostly used in scientific research. And you can see the downstream effects of these genetic components, right? They eventually lead to this, the hormones, as well as then there's the downstream effects of these hormones, like even just mentioned that, the role of progesterone, they have an impact on just different areas of the body, including the brain. Now, gender is different. Gender is more of a social construct, and there's a lot of confusion usually. Both the terms are conflated, but there's a lot of confusion between both the terms, but they're very different. They have, gender is more of a combination of environmental, social, and cultural influences on the biological factors. It's also a way a person represents themselves. It's sort of more of a spectrum where a sex is binary, male or female. And it's also how a person responds to the social institutions, right? And so again, it's very important how we use these terms. And this is more often used in a clinical setting as opposed to, in a scientific setting. So why do sex differences matter? They matter because they have an impact on the anatomy, physiology, onset of a disease, risk factors, prevalence of a condition. And so the list just goes on. It also affects how a drug is metabolized and how well a drug works and what is the safety. So again, when you look at it from the lens of sex differences, I think it has a very important role to play in the biology and physiology. Here I'm just using some of the examples just to show you the sex and gender differences in sleep. And so, for example, men and boys are twice likely to be referred for a sleep disorder evaluation compared with women and girls. And then women show greater objective sleepiness compared to men on multiple sleep latency tests. And there's also a gender bias that many of us are very aware currently in the screening questionnaires when it comes to especially the stop bang. When you look at sex and gender differences in sleep disorders, we know that women are at 40% increased risk of developing insomnia compared to men. They're also at twice the risk of developing restless leg syndrome compared to men, and also have higher comorbid conditions. Narcolepsy diagnosis is often delayed in women, almost by 28 years versus men, and that's 16 years for men. And this is after following, the diagnosis delayed, again, following symptoms. REM sleep disorder breathing is more prevalent in women than in men, especially under the age of 55. Coming specifically to obstructive sleep apnea, it's estimated that 90% of women with severe sleep apnea often go undiagnosed. Postmenopausal women have more partial obstructions compared with men during sleep, and women are less likely to snore, most likely due to their bed partners. Also, there's a lot of information that the bed partners typically tend not to report that, and it's the opposite when it comes to men. But then women also tend to report more sleepiness and more likely to report fatigue and insomnia compared to men. And sleep apnea in women is vastly under-recognized, with an estimated 90% of women with severe sleep apnea going undiagnosed. So you can see there are a lot of examples. There's a lot of new research now in this space. But again, I think there's still a lot more to be done. I wanted to also share some real life examples here. This is a SHINE survey that we did in partnership with Apnea. SHINE stands for Sleep Health Inquiries and Needs and Emotions, looking at the psychosocial burden of sleep apnea in both men and women. And what we found were there were a lot of gender differences. Women reported higher rates of OSA symptoms than men. So there were 78% women expressed feeling fatigued and exhausted. Also 92% of women said sleep apnea hinders their productivity at work and home. So basically there was, and also OSA was impacting their non-work activities. It also had an effect on relationships. 70% of women reported that their exhaustion from OSA affects their ability to be present for a loved one. So you can also see this somewhat matches what we're hearing also in the scientific literature, that there are some real concerns when it comes to women's sleep health. Sleep is very complex. I mean, sleep has different domains. There is that biological domain, social domain, and psychological domain that all act together. That's what makes it so complex. And what I discussed a bit is about the biological domains and the hormones, but there's also the social stigma, communications, and sort of the relational demand that exists. And of course, we've mentioned a little bit of the psychological aspect too. So I think when we think about screening, we think about diagnosis. These are some of the domains and variables we need to take into consideration, especially when we're developing screening tools. So what is the problem in the field, and not just the sleep field? There's been an issue everywhere where for many years women were considered as small men, ignoring their existing sex differences. But that has changed a bit over the years, especially since the publication in 2001 of this report by the National Academies of Sciences exploring the biological contributions to human health. And this report very well laid out that sex actually matters. It's the basic human biological variable. It begins in the womb. That means every cell has a sex, and differences exist from womb to tomb. Sex affects the behavior and perception, and it's the combination of the basic genetic physiological differences along with the environmental factors that create these differences in behaviors and perception. And essentially, sex affects health. So that means we have to take sex differences into account as we continue to develop these new approaches to prevention, diagnosis, and treatment. If we don't do that, we end up with care gaps. And we see these care gaps, not only other areas, including sleep, where symptoms are often dismissed, women are not believed. There's a lack of sex-specific screening tools. There's delayed, that often results in delayed diagnosis, leads to then increased comorbidities. And there's a host of other barriers that prevent women from accessing care. And if you look at eventually, the treatments that come to market, you start to see more adverse events because sex differences or the data was never analyzed based on sex. So these are some of the things I think we need to keep in mind, essentially whether we're coming up with new tools or even when you're thinking about new interventions and treatments. Here's just a real world example that I've used here. So women actually now who are untreated for sleep apnea may be at higher risk for adverse cardiovascular outcomes compared to men, when it was thought the opposite, right? It was thought that men were the ones who are more at risk. And it's the same with heart disease. Women actually are more at risk for heart disease in general. And this is now that we found that there are worse markers for heart injury, and as well as, so this is looking at the troponin levels and also the oxygen desaturation index. These are more associated more with the adverse cardiovascular outcomes in women. So this is just one example. There's quite several in the literature. So here's, I hope I've made a good case for why it's important to not only recognize sex differences and also apply to what we do. And in recognizing sex differences, not only are we going to overcome health disparities, we provide women the care that they deserve. We also give women the opportunity to be as healthy as men. This is an equity issue. We have to think beyond one size fits all approach, right? And sex differences is a pathway to personalized care where we are designing interventions and care appropriate for that person. So you have a woman riding a smaller bicycle that's appropriate for her height, and compared to a man you can see riding a larger bicycle. Again, this is just a good graphic that represents the equity angle. Just wanted to share also this 2024 national poll, which I found very interesting, where on the left it says you can see both men and women are not getting enough sleep, but it's really the women who are saying 36% that they are not get. So there are basically fewer women getting the sleep that they need. But on the right, you're also seeing women responding and saying that they actually have become more stressed, and they're more stressed compared to the men. So certainly something is going on here. And I think this is just something to keep in mind. Again, are these women, are they being screened? Are they being diagnosed? Do we know what's happening? We don't know from this poll, but at least there have been some changes in the last few years. I also want you to take away from this slide that women do often act as the chief medical officer of their family. 51% of the population are made up of women. 47% of them are in the workforce. Women are twice the number of caregivers in the families. They also 65% utilize healthcare right now, and 91% of them have health insurance. And you can see most of them are from employer-based. So again, why aren't we doing doing right by women? And I think this is where I think women themselves need to step up and ask these questions about where is their health and how are they being taken care of. So there are some solutions that I've laid out here. And again, as a patient organization, I think we are empowered to reach out to women so that they can take an active role in their health and ensure they get quality sleep. But also sleep providers can ensure that women, that providers are aware of women's specific health issues and concerns. And we need to enable sleep researchers to design clinical studies and analyze data and report results based on sex. And at the same time, we can encourage the industry to evaluate safety and efficacy of interventions in women and men separately to overcome that equity issue. At ASAP, we have created some women-specific resources, and we'll continue to do so. And this just gives you an example of, the kind of questions a woman should ask. Again, promoting the self-advocacy aspect. You'll also see on the right side an advocacy tool, which I created while I was at the Society for Women's Health Research, but where a woman has, can use this as a conversation starter with a doctor. On the front side are the clues for women to identify sleep apnea, and on the back side is information for her provider. This is a little bit outdated, but we're in the process of creating a more updated toolkit. And just in conclusion, as I'm winding down here, I do want to bring attention to the area of sleep apnea and pregnancy. Often women are not screened and diagnosed for OSA during pregnancy. This is the story of Victoria Stanton, who reached out to us and shared her story with us, who was unable to, knew she had symptoms of sleep apnea, but was unable to get into a sleep study. And her primary care provider also didn't know that they could order a home sleep study. But regardless, I think she is very aware that needs to, keep, again, her OSA went away after pregnancy, but she's aware that she could be at high risk for it later on. But again, this shows that sleep and breathe disorders are reported in only 9% of low-risk pregnancies and up to 70% complicated by metabolic or cardiovascular disorders. And also to some extent in pregnancies carrying a small for gestational age fetus. And again, this is from the publication here, but again, there's so many stories like that we're yet to hear and capture. I'll leave you with this cartoon. This was published in 1991, where a provider is telling a patient, a woman patient, that we have studies of fruit flies, mice, hamsters, frog monkeys, and men with this condition, but medical research using women as subjects has never occurred to anybody. I think we've come a long way since then, but I think there's still a lot of hope for the future that this is the kind of conversation we hopefully will not have in the future, where there's actually a shared decision making. There's enough information that we have that there's a shared decision making between the provider and the patient in exactly, for whatever condition, but especially the sleep, regarding the sleep health. I welcome you to engage with us. We are on social media, as well as I would encourage you to come join us for the Sleep Apnea Education Week, which we launched 2 years ago and will take place April 18 to 26. But thank you again. I welcome any questions that you might have.
Thank you, Dr. Monica Mallampalli, for sharing insights into why sex differences matter in the real world and for providing an overview of presentation differences and sleep disorders between men and women. And she will be sticking around to answer questions, so please put those in the Q&A box now. Next, we will share a quick word from grant provider Cadwell, after which I will introduce our second presenter. And note that the Cadwell video is visual. There's no audio, so I want you to keep your eyes on the screen for 30 seconds of information. Here we go. I am now pleased to introduce today's second and final presenter, Jonna L. Morris, PhD, RN. Dr. Morris is an assistant professor in the School of Nursing, Health, and Community Systems at the University of Pittsburgh. She is also a faculty in the Department of Medicine at the Center for Sleep and Circadian Science. Her research program objective is to generate knowledge to improve care and clinical outcomes of women with OSA. She is a member of the AASM Re-envisioning OSA Characterization Patient-Reported Symptoms Working Group. She is also a member of the Sleep Research Society, the American Thoracic Society, and the Sigma Theta Tau International Honor Society of Nursing. Welcome, Dr. Morris.
Hi, thank you. Thank you for the introduction, and thank you for the invitation to present here today. These are my disclosure, my conflicts of interest. And I'll tell you just slightly more about myself to start off the presentation. I am a women's sleep health researcher and a nurse. I used to work clinically for a long time, but now I have primarily focusing on research, and I am specializing in sex differences in OSA symptoms and presentation, and including sex differences in diagnostic accuracy and CPAP treatment adherence. My current studies use home-based PSG and symptom phenotyping. We're hoping to redefine OSA severity through a sex-specific lens. And I also have another study. I'm looking at peer support for CPAP treatment in women. So in the next few minutes, I'm going to talk about the limitations. So I'm going to primarily focus on screeners, and then looking at screening and looking at the limitations of current sleep apnea screening. Then I'm going to take a closer look at screening tools and performance, and then how maybe we can make those screening tools work better for women. And I then have a few slides on improving diagnostic accuracy. It's another area I'm interested in. And lastly, we'll finish up with future directions. All right. So women present with OSA differently than men, and I think Dr. Mallampalli, I think she's pretty well made a good case for that. OSA is a heterogeneous disease, and I'm convinced that sex differences are a major contributor to this. So when we think about why OSA presents differently in women, several factors do come together. We know that there are a lot of physiological differences in the airway and others. I'm not going to be highlighting them too much during this talk, however. We do know that OSA prevalence increases substantially in women around menopause. Women are also more likely to experience comorbid depression and insomnia, especially at diagnosis, and that can blur the clinical picture. That can also often point providers to alternative diagnosis instead of maybe ordering a sleep test. Women are more likely to be diagnosed with mild OSA, yet the symptoms they report at those mild levels are often equivalent to what we see in men with moderate to severe disease. This mismatch highlights why the traditional apnea-hypopnea index, the AHI, may not fully capture the symptom burden of OSA in women. So I do want to talk a little bit more about what is meant by the impact of gender in my research. So Dr. Mallampalli discussed the differences between sex and gender. I'm just going to talk a little bit further about that. So I define in my research, I define gender's impact as the social cultural behaviors, attitudes, and expectations that are traditionally associated with men and women. So a lot of times they amount to stereotypes, and we know that those stereotypes aren't accurate, but they still influence our behaviors in the ways that we don't always realize. The differences in women's symptom reports may therefore reflect both true physiological variation and also gender patterns in how women's symptoms are interpreted and how they describe them. Social cultural norms can influence then what women prioritize and how they communicate their experiences of OSA. For instance, in my earlier studies, I found women often judge sleep quality by how they feel during the day and not at night, so what their energy, mood, and function was like, whereas men tend to define it by nighttime sleep alone. Also, men may describe sleepiness as dozing off in specific situations, while women experience it as a persistent and omnipresent fatigue. So this raises the question, which is, does OSA severity truly map onto next day symptoms, such as mood, stress, fatigue, and sleepiness in the same way for men and women? Okay, so now I'll talk about limitations in current OSA screening approaches in women. A few years ago, we know the U.S. Preventive Services Task Force found insufficient evidence to recommend for or against routine screening for obstructive sleep apnea in the general adult population. In other words, there wasn't enough data to balance screening's benefits and harms, especially for people who don't have symptoms, which is a lot of people with obstructive sleep apnea don't report symptoms. And so as we know, the traditional symptoms of sleep apnea are daytime sleepiness, snoring, and waking up at night gasping for air, but women often present differently. And I think Dr. Mallampalli did cover a lot of this, but I'm going to reiterate a little bit here. At diagnosis for obstructive sleep apnea, women are more likely to also carry a diagnosis of depression or insomnia. And again, that could mask or distract from the possibility of a sleep disorder. Women may be more likely than men to report morning headaches, restless legs, and less likely to report snoring. And the deeper dive into that, part of the reason they may not report snoring is they may not have bed partners to tell them they're snoring. In 2019, in the US, there were 90 unmarried men for every 100 unmarried women. So it is much more likely a woman doesn't have a bed partner. And even when she does have a bed partner who tells her that she snores, she may still be reluctant to tell her healthcare provider. The consequences of women being diagnosed and not being diagnosed and treated are many. It contributes to a lower quality of life. In the studies that I've conducted, only about 10 to 20% of women report daytime sleepiness. But as you can imagine, daytime sleepiness can affect one's ability to function, complete their daily responsibilities, and maintain relationships. And there are many comorbidities, as we all know, related, such as metabolic disorders, possible risk for dementia. There is some evidence that it could have more severe effect, as Dr. Mallampalli said, on CVD outcomes in women, more so in women than in men. In one of my studies that is funded by the NHLBI, we're working, my colleague and I are working to address some of these limitations by developing more accurate biomarkers of OSA severity that incorporate sex and gender differences. All right, screening tools and performance. I'm going to do a little bit deeper dive here. I found that once people see these examples of how these questionnaires are developed and where the problems emerge, a lot of this becomes clearer. All right, so over the next few slides then, or actually I should just say on this slide, I'm going to talk about the key concepts that shape how we interpret some of these screeners. So we have the basic level, we have this idea called differential symptom expression. And this often is just the basic symptoms. Is it measuring the symptoms that both men and women have? So at a very basic level, a lot of screeners miss this as I'm going to show you. Then at a little bit deeper level is this idea called measurement and variance. It asks whether the tests work the same way for different people in different situations. And because of gender previously discussed, men and women may answer questions differently. So women are less likely to come in and just say, oh, I'm sleepy, I'm falling asleep throughout the day. What they may say is, I'm so tired, I'm having trouble taking care of my children or other loved ones. They might say, I'm overwhelmed with everything I have to do. And in the past, many clinicians might not have initially thought of a sleep problem. And so two ways this could have played out. The clinician might assume depression and prescribe an antidepressant, or conversely, women might be reluctant to say how sleepy they are because of that stereotype that women are supposed to be busy all the time, keeping their house clean and things like that. The idea that they might just be falling asleep in front of the TV or throughout the day, they might not want to admit to. Then there's this idea of somatic awareness. Women report more frequent, intense, and numerous body symptoms than men. There are biological and environmental social reasons for this, but as you can imagine, this could also impact how men and women respond to questionnaires. And lastly, there's the validation gap. Most of these screeners were never validated in women and men or in balanced samples. So, and then as we also know, no two women or no two men are the same, right? There's also age differences, racial differences, different cultural differences within two. So it's really hard to capture. All right, so now I'm gonna do a deeper dive here into the Epworth Sleepiness Scale, which is sort of the granddaddy of them all. This is a questionnaire, if you're not familiar with it, to determine how sleepy one is. It was developed in 1991, and it has been cited, its original paper has been cited over 21,000 times, 10% in the last 2 years, which means it's still being used a lot. It measures sleepiness behaviors. So in other words, how likely are you to fall asleep in front of a TV or while talking to others, but doesn't necessarily measure that subjective feeling of sleepiness that we sometimes get. And in Australia, I recently learned men and women must both score higher than an 8 to be referred to a sleep study. So this could be problematic in some ways. All right, the Epworth Sleepiness Scale can miss women's symptoms because women often describe their daytime impairment as persistent fatigue rather than dozing off. And men may view napping as practical, and so therefore they might endorse those symptoms more readily that measure if they're falling asleep in front of the TV. Several items like lying down to rest in the afternoon may not reflect many women's daily routines or caregiving demands, and as a result, the Epworth scores may not reflect sleep deprivation, stress, or caregiving load, rather than true physiological sleepiness. So that could lead to under-identification of sleepiness in women. So some of the clinical implications here would be definitely it should not be used solely alone for OSA screening. There should be a clinical interview. We should be talking to our patients about the difference between fatigue and sleepiness and what do they really mean when they say they're tired. Is it the fatigue or is that sleepiness? Because that can be used, as we know, both ways. We should also be careful to, support it with objective data, but then also interpret what your patient, your female patient says in the context of how much sleep opportunity do they get? Do they have small children at home, work demands, and caregiving responsibilities? Okay. The other, there's 2 more sleep questionnaires I'm going to talk about, but these much more briefly. The stop bang, as most of us are aware, is one of the most widely used OSA screeners. It was developed for the surgical arena, and that's still used there quite frequently, but it has several limitations for women. The tool automatically gives men an extra point, indicating that men are more vulnerable to OSA, but that does not account for menopausal status. And the tool also performs poorly to moderately in pregnancy. Although it includes questions on fatigue, tiredness, and sleepiness, its accuracy for women remains lower, and early validation studies rarely examine sex-specific performance. But evidence has shown since that if we can lower those these scores right here, so that maybe 3 or 4 women would be considered more at risk, and lowering the BMI cutoffs, we might substantially improve prediction for women. So overall, the stop bang is useful, but you definitely have to keep in mind that women might be underestimating the risk of OSA in women. Okay, the Berlin questionnaire. This is another common one that some of you might be familiar with. It was developed in 1999 for use in primary care populations. It tends to show the best sensitivity across women, but it does include more questions than the other ones, the other screeners, which could increase the burden. It also has a question here about blood pressure, so that, possibly not everybody knows if they have high blood pressure or not. So while it performs reasonably well overall, a key limitation that it has, and so did the stop bang, is that it relies on self-reported snoring. And as I said, women are less likely to report snoring. And so that might also then help to underestimate women's risk for OSA in this screener. All right, so how sensitive are commonly used questionnaires for women? So even those most commonly used screening tools don't really perform equally well for women. These gaps become even more pronounced in special populations. For instance, during pregnancy, screeners perform poorly, and their accuracy changes by trimester and OSA severity. In narcolepsy, women may look the same on the Epworth Sleepiness Scale, but they actually tested more objectively sleepy on that MSLT. So, and they are also, their accuracy increases as OSA severity increases. So they're not as likely to capture women with mild OSA. Again, these screeners then may, contribute to women being underdiagnosed across the lifespan. Okay, so how do we make the screeners work better for women? One of the ways that I thought we could possibly address the accuracy of screeners in women is by establishing different cut points on the questionnaires for women, men and women. So the multivariable apnea index was developed in 1995 as a self-report tool to predict OSA risk in a clinical sleep population. It measures symptoms or asks about symptoms such as snoring, snorting, waking up, gasping for air, and age and sex. But it is similar to the stop bang because the scoring system assigns higher baseline risk to men. And therefore, we hypothesized that it might underestimate OSA risk in women. So this was developed to determine OSA risk of a 10 or AHI of 10 or greater in people with an AHI of 10 or greater, I should say. And in the population that we tested this in, they were overweight and obese, and many of them had type 2 diabetes. But what we found was that it was better at detecting OSA when we included women who had an AHI of 5 or greater. So sensitivity there was about 76%, and if we included women with milder OSA versus 30% when we included women only with an AHI over 10. And when we broke this down further in postmenopausal women, the pattern becomes clearer. If we include those women with an AHI of greater than 5, the tool performed pretty well. In postmenopausal women, had about 98% sensitivity, which was similar to men. But once we just only included women who had an AHI greater than 10, the sensitivity dropped to about 32%, which was lower than what we see in men. So because of these differences, we proposed menopause-specific probability cut points, which are here. And these adjusted thresholds could help improve detection and reduce the number of women, especially postmenopausal women whose moderate OSA might be missed. All right, and then what about pregnancy? Thinking further along the life course. In pregnancy, several factors consistently predict higher risk for sleep-disordered breathing. They were older maternal age, higher BMI, and frequent snoring. All stand out as strong predictors of OSA. And there was this really interesting modeling study done in China that identified additional contributors that were able to predict sleep disordered breathing or sleep disorders. And they were anxiety, depression, how the family was functioning, the symptoms that they were having during pregnancy, pre-pregnancy health, gestational age, and even residence and only child status, which in China were relevant. And they found that their screener had an 82% sensitivity. And so, we see that we can develop those screeners that can really identify, or at least identify higher risk for women for sleep apnea. But the other point I want to make about this slide is that social cultural factors are also help to predict that risk. So it wasn't just those biological symptoms alone. Recognizing, how do we recognize possible sleep apnea then in women's presenting complaints if these screeners really don't perform well? And so, obviously we can review those comorbidities that heighten those suspicions, such as hypertension, depression, and metabolic disease, and consider how gender and social roles may influence symptom reporting, for sure. So many women might describe difficulty managing caregiving responsibilities or feeling consistently overwhelmed, like I had mentioned, and they often report persistent omnipresent fatigue, rather than that classical sleepiness behaviors. So those contextual clues might help to identify OSA risk. And I also want to do a small here plug for these symptom subtypes or symptom clusters you probably all have seen. Another way to think about it is called phenotyping. We know that research shows that obstructive sleep apnea doesn't present as a single uniform condition. It's heterogeneous, and so there are distinct symptom clusters or phenotypes, such as disturbed sleep, excessive daytime sleepiness, and those who don't experience any symptoms. Women are more likely to fall into that disturbed sleep or fatigue dominant subtypes, more so than men. And so current phenotyping work, including our own research, is moving beyond the AHI to characterize night-to-night physiological patterns and their links to day-to-day symptoms. All right, improving diagnostic accuracy. I'm just going to touch on some of these things briefly. Some of them you may have heard of, some of them may not. So home sleep studies versus in-lab testing. Why might home sleep studies be worse for women? The thing is home sleep studies, they don't hook people up to an EEG, so we really can't measure actual sleep, and so we can't differentiate REM from non-REM sleep. Men and women do show clear physiological differences in how often breathing events occur during non-REM sleep. But when we combine up REM and non-REM events into one AHI number, it can mask the fact that many women, particularly premenopausal women, have REM predominant OSA, and highlighting that they're having more respiratory events during that REM predominant OSA, and REM predominant OSA carries its own risks, including cardiovascular strain, more oxygen drops, and worse daytime symptoms. And even though the overall AHI might still be in the mild range. So it might actually be a good idea to put more women in the lab. I'm not sure. The definition of OSA severity is another hot topic right now. And so we know that OSA severity depends on how breathing events are scored. So whether we require a 3% drop in oxygen during those breathing events, as indicated by the American Academy of Sleep Medicine guidelines, or a 4% drop in oxygen for diagnosis, as required by the Centers for Medicaid and Medicare guidelines, that can really impact insurance coverage for women, depending on which guidelines we go with. The difference might seem small, but it has major implications for women. Women in particular have milder oxygen desaturations. So if we expect and we use the stricter 4% rule, we can significantly underestimate their AHI, in some cases miss the diagnosis altogether. So when the measurement system itself undercounts women's respiratory disturbances, we're not going to get an accurate picture of their OSA diagnosis and their symptom burden or anything along those lines. There are some questionnaires out there that people are using, researchers are using, and are being used in the clinic. These are the PROMIS measures. They offer a broader, more patient-centered way to assess daytime functioning than just those traditional sleepiness scales. So the PROMIS sleep-related impairment scale captures how sleep loss affects mood, concentration, energy, and daily performance. So it's more holistic. The sleep disturbance scale is just another measure of overall sleep quality, but they are a little more nuanced and capture more of a holistic picture of daytime sleepiness and some of the symptoms that women have different than men. All right, and then in pregnancy, again, going back to the life course, the Society of Anesthesia and Sleep Medicine and the Society for Obstetric Anesthesia and Perinatology, they came together, they created some consensus guidelines, but both of these recommendations were weak, but they're still as good as we can get them. So they do recommend that women be allowed to test for obstructive sleep apnea at home and not require them to go into the lab, because obviously it's harder sometimes for people, especially pregnant women, to get into a lab, and there might not even be access to a sleep lab close to them. And the other recommendation is, even if somebody does get diagnosed with OSA during pregnancy, we should consider repeating the diagnostic test postpartum. Physiologic changes during pregnancy can influence OSA severity, and symptoms may improve or worsen after delivery. So we just need to keep following those women if they've already had OSA. All right, so future directions. One of the ideas that I really think is really important here is to improve the referral pathways, especially from gynecology, mental health, pain management, cardiometabolic care. Women are getting a lot of care and those specialties, and they can help us catch those women at risk for OSA earlier and more consistently. And then as far as back to those screeners, we need to more focused research to refine how we screen women, including developing sex-specific thresholds, prospectively validating modified screeners, creating pregnancy-specific tools, and ensuring our objective measures reflect women's physiology. Ultimately, we do need screening instruments designed for women that were not adapted from just sort of those male-centric models. And I do know that there are 2 groups out there working on coming up with a screener for women in OSA. So hopefully we might see that in the next couple years. And lastly, my last slide here, which is what are some other future directions that we could be looking at? We could be looking at improving our machine learning models to offer the opportunity to incorporate sex-specific physiology and the broader influence of gender. We can improve our wearables to measure more women's phases, menstrual phases, or maybe improving our measures of them post-menopause. We can redefine OSA severity beyond the AHI so that it better reflects women's presentation, including advancing, including advancing phenotyping and endotyping work. We could improve the accuracy of home sleep testing for women. There are devices out there now that can measure EEG at home and deepen our understanding of REM predominant OSA and improve care pathways and professional education. And lastly, we should be also we can do more work in addressing equity and social determinants in women. So my last comment is that we really can't understand obstructive sleep apnea unless we really understand its presentation in both sexes. That's how we define it. We define it as how it presents in both men and women. So I really thank you for listening to me today, and that's what I have. I think we can take questions now.
Fantastic. Thank you, Dr. Jonna Morris, for explaining screening tool performance and ways to improve diagnostic accuracy for women. And you are right, we are starting the audience Q&A now with some of the questions we've already received, and we would also love for you to type additional questions into the Q&A box on your screen now. Dr. Morris, I have a question for you. Somebody wants to know, can you comment on the Plato questionnaire? Does this help screen women for OSA?
Yeah, that's a great question. I have just become familiar with that questionnaire in the last few months. I do not know that it was validated specifically for women. I think it's a great questionnaire from everything I've seen, and I can't answer that right now. But I certainly think it is capturing a lot more of the symptoms and perceptions of symptoms that women have than in the past.
Excellent. Dr. Mallampalli, from a scientist perspective, can you address HRT hormone replacement therapy at all and how it might impact sleep? A few folks are asking about estrogen replacement, hormone replacement therapy for women.
Yeah, thanks, Sri. I think there's a lot of conversation that's happening in this space. I mean, essentially, the thought was, women who have bad vasomotor symptoms is what affects their sleep. So, and there's a lot of, again, subjective reporting to show that women do feel better once they get on HRT with respect to the vasomotor symptoms. Now, regarding the sleep, again, subjective, that women might be sleeping better, but I think I have yet to see proper concrete data. And again, I'm not really caught up on the full science here yet, but I think they may be, again, approaching from the vasomotor symptom aspect. I think HRT is useful. But again, we need to see more research in this space specific to what's happening with women's sleep or more objective data.
Excellent. Dr. Morris, a few folks are wondering if you can dive any more into how menopause affects sleep.
Yeah. So as Dr. Mallampalli was just saying, we know that there's a lot of more vasomotor symptoms, hot flashes that women are having at night that can really contribute to waking women up at night. And insomnia is much more prevalent during menopause. The rates of insomnia increase greatly when women go through menopause. And so sleep through menopause is for many women has become a challenge. And there is a lot of research being done into this area of it. And I think in terms of obstructive sleep apnea, where I can speak a little more closely, it is really hard to know. We run into a problem too with women and going through menopause and their hot flashes, and whether or not they're waking up from their hot flashes or waking up from the arousals that they might have, during their breathing events. So it gets to be very complicated, and it's hard to know, why the risk of obstructive sleep apnea goes up, at that menopausal transition. So there's still a lot of research to be done yet.
Excellent. Dr. Morris, I'll ask you this one first, and then Dr. Mallampalli, if you want to jump in after, you're welcome to. Somebody asked, if I do 300 plus HST per month on women, how should I adjust my screening and diagnosis?
Oh boy, that's a loaded question. And it's a good question. So, right, as I said, the home sleep studies do not actually measure EEG. They do not measure sleep. They are the best that we have, though. But they do, there is a lot of research out there to suggest that they misdiagnose many women, especially because we don't know if they're sleeping. And it also depends too, those home sleep studies, I'm imagining most sleep clinics, the sleep clinic that I'm familiar with, they do score them by 3% and 4% oxygen desaturation. But again, if you're using the 4% oxygen desaturation, you might also be missing women, regardless of whether it's in a sleep lab or a home sleep study. It is hard. I think it's. I have known women who have described every symptom and were convinced that they had obstructive sleep apnea, and the studies kept coming out with an AHI of 3, an AHI of 4. And I've talked to physicians already that will order repeat studies. And this was something I probably should have mentioned during the presentation, that it is okay to order repeat studies. I knew a physician that ordered about 3 or 4 repeat studies on a woman, and I'm not quite sure how insurance covered that. until they got her HI up to a level that allowed her to be treated for her sleep apnea. So it is hard. So it's a combination of screeners and clinical discussions and things like that, along with the sleep study.
Yeah, I just would also like to add here, I mean, this is what Jonah said, you know, I've had somebody come up to me and said that they scored negative even on a repeat test, but when they went into in-lab, they were diagnosed as moderate. So this is something that we also, you know, mentioned in the advocacy toolkit that we created in messaging to women, that if you suspect you have symptoms and you're coming up negative on your home sleep test, do a repeat test, or at least ask for an in-lab study, because I think PSG is better at picking up sleep apnea in women. But again, there's a lot of work that's needed, and we need absolutely more clarity in how we are screening women in the home sleep test.
And Dr. Morris, I'm going to ask you this. It's not actually in the questions, but I've written an article about it recently about all the type 2 home sleep tests that have the EEG. They're kind of new. They're not really covered. They're covered, but they're not covered maybe at the rate that people want them to be. But is that something you're familiar with? Like a couple brands like Onera, Somnomedics. I think there's several that are coming out now that actually do have limited EEG, maybe just a frontal. Is that something you're familiar with? Do you think that would be better?
Yes, so I'm very, very familiar with it. My one research study, we used the NOx A13 to measure our participants' sleep. And it is a little bit more burden. That's the catch. Well, there's actually 2 devices I could quickly talk about. So the NOx A13 is more burden. They do have to attach leads to their head. There is recently FDA approved in the United States is sort of a tool that participants can use to attach it very easily, so they get it in the right places on their head and measure sleep correctly. But it is accurate, and it is EEG. It's limited. It's not the same as like an EEG in a sleep lab. It's not as many leads, but it still gives us a good idea of REM versus non-REM sleep at least. And then, you know, so that one and the other study, the other device we're using is the sleep image study, which is just a ring. And that's really where they have a built-in cardiopulmonary algorithm. And that does approximate REM versus non-REM sleep to some extent. It's not the same as the PSG, but so these tools are coming out and they're getting better. You know, like I said, some of them are more burden than others, and that's the problem. It's really hard to get a lot of people to put a whole EEG or even a partial EEG on at night. We have to actually pay them to do it. So, but hopefully that'll get better.
Excellent. And this is kind of, I guess, related. Somebody wants to know if there's any examples of, they say, the best HSAT available for women that may help identify REM-associated sleep disorder. Do you think that's also one of the EEG ones?
Yeah, so I know that watch pads become very, very common, but again, it's not going to be as accurate. I don't think it measures even REM versus non-REM sleep. So I would say that, yeah, there are devices that are coming out that are getting better at it. They are just, and some of these companies, unfortunately, it's hard, they're startups, and so it's hard to get going, and they might have a good product, but it doesn't always take off. And so, yeah, the work is ongoing.
I want to bring Dr. Mallampalli back into that conversation before we close. This is a bit of a provocative question you both might want to weigh in on. Would you assign different HST devices to men versus women? Dr. Mallampalli, do you want to weigh in on that?
That would be fantastic, right? If we have, but I think even collecting the data, the way we're collecting the data and the way we're analyzing the data, I think is something we can focus on. But clearly I'm supportive of the EEG aspect for that, but I will leave it to Jonah to answer that question better.
Yeah, one thing I do not know, and this is actually an excellent question, is where did they validate a lot of these devices? Were they validated in both men and women? In almost all those devices, you know, they've written some papers and they provided some evidence, but quite honestly, I have not seen a lot of evidence validating in both sexes. Mm-hmm. So that is, I could not at this point recommend one either, in any direction, because I don't know.
And I just want to add to that. I mean, this is something, again, I spoke in my presentation, even when we're creating any new devices or anything. I think it's just keeping the sex differences in mind while even designing something like this, knowing that you're going to be measuring in men versus women and how you're collecting the data, how you're analyzing the data, I think is important. And I think there needs to be that awareness upfront while even before conducting.
Fantastic.
Yeah.
Well, I am feeling much more informed. I hope all of you are too. I want to thank Cadwell for providing the educational grant through its CADCare education program. You are welcome to reach out to me, Sri Roy, editor of Sleep Review, with comments at editor@sleepreviewman.com. Also, please take the exit survey that will pop up when you leave today's event. Thank you for joining today's webinar, Improving Sleep Disorder Screening and Diagnosis for Women.